Thank you all for being here. This is my 5th year. This is my continuing education in nursing science. Every reunion weekend, as my wife pointed out to me today, I get to moderate a panel discussion with a room full of people who know more about the subject than I will ever know or ever imagine I know, and I'm not just talking about the panel. But we have a great panel here today, real all-stars, and I think I know this is the first dual Kelher Award that we've given out, but I can't imagine a more apt two people. They are like the hot dog and mustard of ethical nursing ethics and healthcare ethics. Every time you see one name, you see the other right next to it. And Professor Grace Pamela Grace is not in there too.
She's the relish.
What's that?
The relish. She's the relish.
I like that. You know, I was going to tell Pamela, I was going to say, and I'll say it, might as well say it now. She is, and this is a cliche, she wrote the book, period, end of story. Anybody in this room who has studied or practiced nursing and from an ethical perspective, has done it through Pamela, and that's all there is about it. You know, of course, the ethics of medical care has a very long history, and I looked up the Hippocratic Oath today to see how awful it was. It wasn't awful at all. It's pretty good, except for the fact that you get to swear by Apollo, Asclepius, Hygeia, Panacea, and all the gods and goddesses. But what comes out at the end is pretty close to what you all do, those of you. Is this on?
No.
Does it matter?
It does for the video.
Okay, forgive me. So, do I have to do that all over again? Do I have to do that? I knew I should have taken the easy way out. Is that on? Thank you. I guess everything I just said is down the drain, sorry. But I will get to read something from the Hippocratic Oath for the record. I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. I will give no deadly medicine, which turns out to be pretty apt today, in spite of the 2,500 years that have passed. I will enter a home only for the good. And while there are not so many home visits that many of you make, though I'm sure some of you must make home visits, this is true with hospital rooms as well, obviously. Now the question why we're here today and why these folks are so important, and many of you are so important, and challenged, because the question of what is the good that you're going to do when you enter a home has become so complex. Technology is part of it, certainly, but so is the demand for transparency. I lost both my parents recently, and my brothers and I and my sister asked questions of the healthcare professionals that my parents would never have dared ask of healthcare professionals in their time, and insisted that we have straight answers. And also, we all become experts. That is, I become an expert by looking up something on the web, and I determine what the best course of care is. How often, I have a wonderful physician who I've known for 35 years, and every once in a while I come in for something and I say, well, Maury, I looked it up on the web, and I see his eyes just glance. I think my blood pressure is different on my right arm than my left arm. I've got a real problem. I read something on the web that said it predicted something. So it's much more complex, particularly with end-of-life issues, but I have promised Martha we are not going to dwell on end-of-life issues, because there's plenty of things to talk about in terms of nursing ethics. And here's a trigger warning. I've never had a chance to use a trigger warning. I guess you all don't know what that is. I'm supposed to tell you, like I'm the shock, a room full of nurses, right? We're going to use the terms autonomy, beneficence, and non-maleficence.
Non-maleficence.
There I go. Thank you. Well, I'm not going to use that one, obviously, but somebody else. Let's begin with our award winners, our honorees. And let me ask each of you to offer your definition of what healthcare ethics or nursing ethics, using either term, is, and give us a demonstration, a case, if you will, on how it's worked in your careers, your lives, and particularly a case that really taught you something, that left its mark. So let's begin with Ellen.
Okay, thank you. Well, I think when I think about healthcare ethics, I think about it being a way to provide a framework to talk about complex, difficult, conflictual problems in the healthcare arena by using various languages and approaches that often serve to actually raise up, not take away the emotion, but we all identify with these issues maybe and may respond, for example, with an emotional statement. So when a nurse, for example, may call and say something like, well, this is really ridiculous. This isn't right. We're torturing this patient. Frameworks for healthcare ethics allow us to work with the nurse and other health professionals to actually try to cull out what the issues are. Ben mentioned the principles of medical ethics: autonomy, beneficence, non-maleficence, and justice is increasingly becoming, always has been, but it's one that we will have to embrace, I think, even more and more, and should embrace. But if we can help nurses be able to talk about what it is about the case, for example, translate their emotion into, I'm concerned that we're doing harm to this patient. I'm concerned that harms exist, for example, and benefits are no longer present for the patient. I'm concerned that in reality we aren't necessarily honoring the patient's autonomy because his or her surrogate decision maker may not be accurately representing that. And that, on the part of the surrogate decision maker, is not necessarily an ill-intended act. Research has shown that healthcare decision makers for others, family members or others who are healthcare agents, often choose more aggressive treatment for their loved ones than they would for themselves. So this is some of the ways I think that healthcare ethics can be described. And lastly, I would like to just put in one particular piece related directly to a nursing philosophical approach to ethics. We often hear discussed or mentioned that nurses are in concert with an ethic of care or care ethics. And I feel that as nurses, this is what staff nurses, clinical nurse specialists, and nurses in the positions that Martha and I are in can bring also to these difficult situations. To operationalize an ethic of care, we have to ask the question, who is this patient? And learning the particulars of this patient, which basically leads us to find out, how is this person responding to his or her disease? If you took 5 patients the same age, same sex, and who may have had the very same kind of heart attack and did autopsies on their hearts, you would possibly find the pathology to be very similar. But those 5 persons with that cardiac pathology are 5 different persons responding and living with cardiac disease. And this is what nursing seeks to uncover. So as a nurse ethicist, we bring this framework in to the patient situation, to the discussion. And another tangible of an ethic of care that is so very important in these conflicts is the idea of relationships. Now, as human beings, we all are in relationship. So autonomy isn't necessarily individual. We're perhaps involved in more relational autonomy with our families, our communities, and so forth. And in our human strengths and in our human brokenness, human beings have relationships that are positive and also relationships that are possibly not so positive, but yet still important to the patient. So in healthcare ethics, we aim to learn that, respect that, and work within a framework that will bring the level of conflict down.
Let me ask you, Martha, what would you add to that?
So I would agree with everything that Ellen has said, not surprisingly.
The literature suggests.
And would add to it a slightly different frame, I guess, or angle on ethics. And one of the things that I learned here at BC and continued to learn as I started to practice ethics was a lot of the issues of ethics are engaged in how you frame them. And there's usually more than one frame that one can draw around an ethical problem. So ethics at its heart is about the questions of what's right and what's good. And the questions of what's right and what's good underlie all of our work as clinicians, us as nurses, our physician colleagues, and we only begin to notice issues of ethics when there's a rub, when there's a conflict, when there's a difference of opinion, where there's some misalignment. And it's then that we say, oh, there's an ethics problem here. And part of the challenge, I think, is in seeing that ethics is ubiquitous. Ethics is everywhere, and it's only when there's conflict that we begin to notice where it bubbles up. So.
Thank you.
Mm-hmm.
There has been a burgeoning, I think, what were you telling me? I believe, Ellen, correct me if I have the numbers wrong, 50 to 75 to 104 to this year 120. What do you call them? Ethical meetings or
Consults?
ethical
Yes.
consults at MGH. This is an astonishing growth over very few years. What's behind that? I mean, I mentioned technology earlier, but and also the issue of transparency. Is there a cultural change that we see in hospitals where just what is happening that is driving this?
Well, I think it is multifactorial in many ways, and you mentioned some of the main factors. Technology, particularly in these sort of leading hospitals in the country, there is always going to be a push for technology, a push for innovation, a push for research. And this is, of course, not a bad thing. It's a good thing. And many of us who are sitting here today have possibly ourselves or through our families, for example, realized the benefits of advances in technology in cancer treatments and so on. But one of the things that hasn't been as, it's difficult in real time, I think, when a patient, a family member is very ill. We're not prepared, or families aren't ever really prepared to lose a loved one. And so when you place a sick person in these settings with a high drive for technology and innovation and sort of a one of that kind of American dream, American drive to live, that we value that and we want that. And so much can often be done to restore a person's health, even if it is to a reduced level of quality of life. Nonetheless, it's an acceptable quality of life to that person and family. But finding that line where the benefits still may be possible and the burdens are not yet terribly excessive is a very difficult line, to find.
Sure. How about other issues aside from an extension of life or end of life where ethics are?
Yeah. One of the major ones that I think we see more and more in the global culture that we increasingly live in have to do with how we reconcile what's good and right in a particular culture and yet may be different in another culture. We work in institutions, Ellen and I, where we have international patients, and even just within the greater Boston area, there are many cultures and religions represented. And so the question of, without a slide completely into cultural relativity, in which whatever you say is right, there's some line there. But determining what the line is the work of ethics consultation. Yeah.
Which one of you had the Nigerian patient? That was you. Could you say?
I'm sure Ellen has had Nigerian patients too.
I'm sure. But the relatively young man who had a heart attack, was it?
So it was not he who was the patient, actually, it was his sister who was the patient. And she had cancer that was diagnosed quite late. And she was, and it's not unusual, she was maybe in her 40s, had lived in this country for quite a long time, had been visiting family in the Baltimore area, became ill, wanted to come back home quickly, was almost immediately admitted to the hospital, and over the course of about 3 weeks, declined very rapidly. So she had a widespread GYN cancer that had metastasized, and no one was prepared for how quickly she was dying. So by the time I got engaged in the situation, it was a call from the surgical intensive care fellow who said, this family is very religious, and they are hoping for a miracle to happen with this beloved sister, aunt, person, and she's got multi-system organ failure, and she's dying, and we need help. And what he wanted was at least a DNR order. So those of you who deal with this will appreciate the challenge of that. The resuscitation limitation is often the first step toward limitations of treatment. And so he asked for an ethics consult. So the format for an ethics consult is involving, as Ellen implied, all of the involved parties. So it means meeting with the family, talking with the patient if that's possible, and talking with the treatment team. So I met with this brother who was, when I met him, sitting in the waiting room, he had a suit on, and he was praying. And was sitting quietly in the hubbub of this family waiting room, just praying. And I introduced myself, and he was gracious, warm, loving, clearly, and was shocked by his sister's quick decline. He had been appointed healthcare proxy agent, and we talked about how decisions in his culture were made. And the clinical team wanted him to authorize or agree with them about not attempting resuscitation. And he said, well, that's not how we make decisions. We make decisions by the whole tribe. And I've been in touch with the elders in my family back in Nigeria almost daily in trying to make decisions about how my sister should be treated. So the short story was that we met together and included by teleconference the family in Nigeria. The team, however, had a hard time saying, your sister is dying. And we talked about it before we went into the meeting. They could not get those words out. So they said, she's very sick, her kidneys have failed, her lungs are failed, and the family in Nigeria said, well, treat it. I mean, she's in Boston, that's why she's in the hospital. It's like, and I don't mean to make light of her plight, sorry, but it highlights the expectations that Ellen was talking about in terms of technology use. And so we were, you can imagine, we're on a teleconference, the family's in Nigeria, where this opportunity doesn't happen frequently. And so I decided that it needed to get said, and I said to the physicians, have you told the family that you understand that the patient is dying? And they said, I said, do I have that right? And they said, yes, she is. So that changed the conversation, because understanding that she was dying meant, of course, something different than her kidneys are failing, her lungs are failing, and it's multi-system organ disease. And with that, it helped the family to understand that the end of her life was near.
Thank you. Thanks for telling that story. I want to turn to the teachers now, the people who try to prepare nurses to deal with these kinds of circumstances and much more complex, and as I understand it from reading, sometimes very hostile conversations. So let's begin with you, Pamela. If you, how do you prepare? And we're talking about graduate nursing here. It's, I guess you do teach an undergraduate. You don't teach an undergraduate course.
I do. Well, I teach undergraduates as well, and in fact, in a sense, they are the ones that need most to be prepared, I think, to go out and deal with some of these very complex
Understood.
issues.
Well, why don't you talk about how, what are the rules of engagement for you? How do you teach nurses to think about this and behave?
Yeah, so first off, I think it's very important for nursing students, whatever level, to understand that they have a certain amount of knowledge about what should be going on with a particular patient. They have the skills and they know that their professional goals are about engaging with patients to help them figure out what they want to do. And so not all of the things that we prepare students for have to do with the dilemmas. We talk more initially about the fact that nursing is a profession that, in a sense, has a fiduciary aspect to it, in that people who need nursing care do not know what it is they need or cannot meet their own needs. So they rely on the nurses to actually keep their best interests in mind as they're engaging with them. And so what we try to prepare the nurses for at all different levels is how to articulate what a problem is, even a daily problem of practice where perhaps there aren't enough nurses, or the physicians have conflicting orders, or the institution is pushing the nurses to do the tasks quickly, and that might shift the perspective then from thinking about the person as a human being. And that's particularly true with new nurses, because of course they're learning the skills and they need to know how to do those, and it's very easy for them to sort of forget that there's a person underneath it. So the first thing I think we try to get across is how to keep in mind at all times that there are goals, that there are nursing goals that we're there to try and fulfill, and that patients are depending upon us to do that. And so regardless of what else is going on in our lives, emotionally, or you know, maybe I'm going through a divorce, or I've moved and I have no friends, or whatever, or I'm taking finals, or whatever I'm doing, that those have to be put aside to take care of the patient. The other way we prepare them is to think about their own biases and how those interfere with decision making. So you know, I'm not going to repeat the framework part, because of course that's an incredibly important part. But what we do try to get them to see is that the language of ethics helps them articulate what they already know to others in order that the patient can get what they need. And so that's both at the undergraduate level and at the graduate level. Is there anything else
We can come back.
Yeah.
Father Ross, if I could ask you to comment on two things. One is, when you and I talked yesterday, and I've talked with everybody on the panel, when you and I talked yesterday, I asked you how a Catholic or a Jesuit Catholic, offer a Jesuit Catholic reflection on ethics, of course, goes beyond any particular religious faith. But the other thing is, you also mentioned the kind of nursing student we get as undergraduate, generally from a privileged background, and then goes to a hospital, say in the city of Boston, a major hospital, and gets to work with people. Now, you know, Nigeria and the United States are certainly separated by culture, but so is poverty and growing up in Needham and Newton wherever else our students come from. So could you talk about those two things, the Jesuit Catholic aspect of this and also the class business, if I can call it?
Oh, sure. Well, I think probably from a Jesuit perspective, our main approach would be, and we do this in our ethics class with sort of a method. And the method simply is we ask the students to make a connection between what they're learning and who they are as a person, because we hope that the content of their learning will transform them. And so how we go about that is sort of a method, and it's true with the freshmen in the Cannell School all the way up to the doctoral program, is we ask them to write reflection papers. And they will have a response, whether it's to an idea or an article, and the content of our ethics class is mainly articles. And they're going to be introduced to ideas and concepts that are going to challenge them. And so we ask them to go into that, to think about that, to react to that. And also, as Ellen said, we want to know how they feel, because we're talking about a person. And so hopefully through this kind of a method of reflection, and they do it in their clinical courses, and they do it in their theory courses, they do it in their doctoral courses, it's transforming. Let me give you one example. I had a senior when I was teaching professional nursing 2 who her clinical was at the Barbara McGinnis Homeless Center. Privileged background, our students, many of them do come from upper middle classes. Do you think she'd ever met a homeless person? Of course not. But she wrote her paper and she began to meet the people at the center. And she discovered that the circumstances of their lives had changed them and left them homeless. Some of these people were highly educated. Some of these people had struggled with addictions. She learned who they were, and that shook the student up. In reflection, we always come to a point where we think about what does this mean for me as a person, and where am I going to go? What am I going to do with this new knowledge? You know what she said? She said, when I walk through Cleveland Circle and I pass by a homeless person, I'm not going to just pass by and not look at them. I know who they are. I'm going to stop. So that's an example of, say, someone from a higher social class. And when our students go in, so it's a challenge for us as faculty when our students go, because actually the Nigerian person or, the people in Haiti or wherever, that's how most human beings on earth live. That's our world. And so how do you deal with this? How do you cope with this? What are the questions? Asking the right question. So we're constantly trying to determine what are the right questions for our students to ask. And we do it through this methodology of reflection, because reflection leads to change. It does something to me. And what is our goal? As our panelists have mentioned, our goal is the good of this person, the Nigerian family. What is the good? We have to discover it. And Ellen mentioned that the nurses, they're stressed. I want to help them. And I have these feelings in me. Where do I go? What do I do? And so through the education in Cannell, we give them not only a framework, but we also give them a way to understand themselves so they themselves are transformed. They discover who they are. So it's, Ben asked me, I had gone to nursing at Michigan, which is an elite nursing school, fabulous education. It gave me a foundation for life. But how is it different, he said, than, say, Cannell School? And I can tell you how it's different. And we can look at our panel here, and I'm looking around. I'm in a room with Cannell nurses. So I think that's the key, is who are you? Where do you want to go with what you've learned? Because in the reflection papers, we're trying to inculturate a love of learning. Have a love of learning, then you can fall in love with the world. and you want to care about the world. So we want them to care about their learning, and we want them, that transforms them into action so that they care about our world. If I went around the room, and as I did before, I got to speak with so many of you, and we would have a story with all of you from your memories. And I hope that some of this resonates with your education from generations ago. And I know it does because I just, before I came in, I spoke with someone from the class of '59, and she told me a story of how she learned. It changed her. She became a clinical instructor in Florida, and she had learned something here about how to understand the student. How does the student learn? Knowing how the student learns helps us to create, as we say, you know, you hear some of the expressions, men and women for others, people who excel. A love of learning is really kind of what, anyways, that's a little bit about maybe some of the different, that is a very Jesuit way, let me just say that that's sort of, that, because ultimately, you know, just from a religious sense, I'll say it, but we would say that we find God in the world. Many of you have heard this before, and that's why we want you to love the world, to fall in love with the world, to fall in love, because that's the pathway to God. So that's, you know, you could be an agnostic or from another tradition, that's fine, but it's a bridge between religions, between people. It's a way of learning, a way of love of learning. So anyways, that's a little bit about how the challenge is for our undergrads. And I would just say one last thing. I mean, I had a senior class this year of synthesis. With these reflection papers that they write become a habit of mind, so that when Ellen and Martha meet nurses, hopefully Cannell nurses, in the hospitals, they have this habit of mind to be able to step back, think about the situation. What does it mean for me? What's it doing to me? Have a framework to think through it and reason through it. And so anyways, in the synthesis course, they choose a clinical site of their own, and they get to pick which hospital they go to and so on and so forth. And you know, they want to go to the ER, and somebody in the ER, and somebody was in a burn unit. I couldn't believe it. But they write 4 reflection papers. They just spill their guts. They tell you in 3 pages how they've been challenged, where they're going to go with it, what they want to become as a nurse and as a person in 3 pages. It becomes a way of thinking, a way of being a person in the world. So that's a little, maybe from a Jesuit perspective, what we understand. And you know, I know that so many generations here in the room, and I think that maybe, you know, the methodology of the formation changes over the years, but the goal is the same. The goal is the same, that you, men and women, for others, for service, for God and others, essentially is the bottom line. And how we get there maybe has changed a little bit over the generations, but this is how we're doing it now. So.
Thank you. Thank you very much. A few years ago, I was hospitalized for a little while, and I was always tempted over at MGH, a wonderful place, by the way, very highly ethical. And I was always tempted to ask each nurse who came in where they graduated from, but I knew I'd only grin if they graduated from the Cannell School, and the others would see my face fall when I learned they came from perfectly wonderful schools like Michigan, Father. But that wasn't the Cannell School, and I knew the Cannell School and trusted the Cannell School nurse, so thank you for that articulation. I know there's something special that goes on here. Now, let me quickly ask each of you one question, then we're going to go to the audience, and who I know, I'm sure, has their own questions and reflections here. If you had, all of you have been in the trenches, and I said there was I think it was in your Vita, where you were saying how many people you had taught. And I think you dismissed this question by saying countless. Can't count them up over the years. I imagine informally, because of your position at the hospital. Let me ask each of you what reform you'd make, if any, one change you'd make, either in nursing education or in the way nurses are deployed in healthcare, that would, let me say this, that would help patients and their families and the physicians and everybody else to move to to more easily make decisions that were ethically right and ethically appropriate without taking as long as it sometimes happens, as you referred to.
Okay, thank you. I will focus on a change that I would make for graduate education in nursing. I'm specifically thinking of the master's degree, clinical nurse specialist role, advanced practice nurses, nurse practitioner role. Increasingly, we have the nurse practitioner role in acute care as well as across the healthcare continuum, and I think it's a very good role. It is a role that allows the nursing philosophical disciplinary approach to be really front and center with the medical care approach, and it often serves as a fantastic bridge between the physician and the staff nurse, clinical nurse. Because of all that we've talked about here today in terms of the complexity in the issues, and they're increasingly so as well, I would say that it's a wonderful part of the curriculum here that these graduate nurses have an ethics course. I would link it with a clinical ethics experience in one of the hospitals with a nurse ethicist role. I think that it would strengthen the ability, for example, for nurse practitioners to be able to clearly identify what the complex, conflictual issues are when they get out to clinical practice, and they actually do have a role in bringing these issues forth with their physician partners, and it would strengthen them. It would strengthen their skills in being able to work through some of this while they were in an educational role. And I believe that grant funding organizations would be interested in this kind of collaboration between academia and the hospitals.
Thank you.
That's a great idea, Alan.
Are you going to steal it now?
No, I'm not. No, I'm going to build on it. It would be easy enough. I was like, oh, that is a great idea. But my building on it would be to institutionalize the opportunity for reflection on a regular basis in the clinical setting. So what I would ask is, on a weekly basis at least, there's time taken in an interdisciplinary dialogue to reflect on what I like to call the ethical worries. So it doesn't have to be a dilemma, but it's the ethical worries with a group of patients that are on this floor now. Let's take a half an hour to talk about it this week. And it's facilitated by a nurse ethicist. Yeah. So after they've done the training that Alan's.
Well, so I would say if we get your model, that would be a perfect model then for the undergraduate curriculum, because I think perhaps our students are better prepared than many because they have a strong liberal arts core. But many nurses, when they get out of nursing school and they're into practice, they really don't know what they know and how what they know can make a difference. And so I think if they had clinical instructors who were very strong in ethics, that would prepare them as a sort of diffuse thread throughout the curriculum, so that by the time they graduated, they might be very novice at it, but they also would know where to go for resources when they had trouble, how to sit back and think about what the worry was, attend to the worry if possible in the situation, but if it's not possible in the situation, then how to address it at a bigger level, like at the institutional level. Or not all of our nurses are in a hospital setting. Often they're in primary care on their own, trying to do the work, but they would have then the preparation, the network, to have a forum to talk about how should we deal with this. Because a lot of the problems that face nurses in practice are actually bigger socio-political problems that they need the skills to address. And there's so many nurses that if they had the skills to address them, we could be a really powerful force for change.
Thank you. Father Ross?
I would say the same thing with the undergrads. I one time, with the same professional nursing course for seniors, I asked them, have you been able to identify a problem in your unit that there could be potential harm to your patients? What do you think happened? Do you know that all of them were able to identify something where they saw something was going on that would be potentially harmful? And so then I asked them, I put them in groups and I said, could you think of a solution? You see this potential harm. Can you find, and they all worked together and they began to think about a solution. But again, so I would say we don't have anything formal in the undergraduate program, but to introduce, as the others have talked about, a framework. They have a sensibility of what are very concrete problems. I mean, let me give you just one example. They learned in Skills Lab how to put a urinary catheter in, but they get into the setting and it's not happening that way. They're cutting corners and so forth. What do I do? You know, it's as simple as that, where there could be a potential introduction of infection or whatever. But anyway, so I would echo what the others have said.
Thank you. We're now going to turn from the panelists to you. And I think we've got a couple of microphones so that, unlike me, you can be heard. And you want to take this one? You sure? Any questions? Or in this forum, actually, we take comments because I've noticed over the years the comments have been extremely astute. I sometimes want to ask people, come down here and take a seat with us. Please, let's open it up. Anybody? Who will begin? Here we go. Thank you.
At the beginning, we hinted at the word access to care. And I believe that that is really a very critical issue in terms of ethics and justice. Could you comment on what your experience has been so far with the access to care? How do institutions handle that? What structures have worked? And what areas need improvement?
Well, we are fortunate in these two large Boston hospitals to be able to open the doors to all who need care through the emergency departments and hospital admissions. However, increasingly we are seeing a disparity with discharge planning. Increasingly, it depends really upon what type of insurance or Medicaid, Medicare that you may have for coverage that will greatly impact the kind of discharge plan that can be put together for you. This includes, of course, undocumented immigrants, but is also cutting across the general, citizens of the United States who may have lesser, coverage in terms of their insurance policy than others, and it is emerging as a problem. And it's a great dilemma for the nurses because they want to send people out with the very best kind of follow-up that is possible for them without calling on Peggy, somebody in the audience who's a recent doctoral graduate, but I know the nurses in her unit, the neonatal intensive care unit in particular, struggle with this when they care for so long for these neonates and then feel that they may be sending them home to situations without the best of surveillance, provision of care, and so forth.
So I'd add and probably push the provocative envelope by saying that although we're very lucky in Massachusetts to have the kind of advanced coverage for healthcare that has helped to address a lot, but not all, of the access issues, that we really have to disconnect the market model from the healthcare model, and we need a single payer system that allows everybody to get the care that they should get. So.
So that was our political action, so.
Okay, next comment or question?
Thank you. Do you see any way that we can get the ethics to keep up with the massive advances in technology that we're getting? I just feel like technology is going so far ahead of our ethics, and I don't know where we go from that.
Anybody? Pam, how about you?
Oh, that's
Put you on the
yeah,
spot.
that's a great question. Yes, I think that one thing that needs to happen is that more money needs to be put into looking at the ethical issues. So, for example, the genetics movement, only 5% of the budget goes to ethical, social issues related to that. I think having more minds brought to bear on that problem is what's required, and I think time to think about those problems is another thing that's required. And so what you have at the moment is a lot of researchers pushing the research forward, but not a whole lot of people looking at the research to say, oh, wait a minute, what's this doing? And also to relate it to issues of social justice. Like, we're busy doing this, is that the best use of our money when huge swaths of the population can't even live a minimally decent life? And that kind of goes back to in this country, it goes back to divorcing the market model from the social good model, right, for healthcare anyway.
Thank you. Please.
It seems to me that we have given a lot of attention to the advocacy, the nurses advocating for the best and the good and so forth. But given there are so many complicated situations where there is conflict, where people don't agree, whether it's amongst clinicians or with patients, I'm wondering what attention is given to the concept of integrity-preserving compromise in the teaching of students.
I think I've seen what these folks have written, and I think any one of them could take this on. Please.
I did, right, about, yeah.
So so what we're saying down here is that I had written a short piece on integrity, preserve, and compromise, not in terms of education particularly, but in terms of the acknowledgement of it in the clinical setting. And I think, so maybe this will inform what needs to happen in education, but a first step, I think, is to expect conflict. We live in a morally diverse society where there's lots of ethically defensible answers to the question of what's the right thing to do. So rather than be surprised when somebody else has a different answer than we do, there needs to be more of an expectation, an acceptance of people are going to arrive at what's the right thing to do differently, and how do we accommodate that, negotiate that, how do we decide where the limits of that are? Because it isn't all good. We agree that there's some stop point. We may not all agree on what the stop point is, but there's more room for conversation. So perhaps the educational offering is skills on conflict management, skills on communication, the ability, and Ellen and I see this in the work that we do, on talking with people who hold a different point of view, who may be at a different power level in the organization, and be ready to engage in a perspective and point of view that may be different from other people's, but which needs to be heard.
I was just going to speak, we could speak about this together, but we intentionally have methods in both the undergraduate program and the graduate program to take diverse students, put them into groups. They cannot be in groups by themselves. And in our ethics graduate class, we get a card with their backgrounds, their specialty areas, and we intentionally mix them up so they can't be with people who are all in women's health and so forth. That's a way for them to get a different perspective and to also articulate what their position is. And in some of the assignments as well, they not only make their argument, but they have to, in the paper, say, if someone doesn't agree with you, what do you think they would say, and how would you respond to them? So we are intentionally teaching them that they have to communicate, they have to be able to have a vocabulary, a way of thinking, because there will be conflicts of interest in the clinical settings. And I know in the undergraduate program, we just had a program evaluation day. One of the professors had mixed the students in a different way, the sophomores, to put them into different kinds of groups, and they have to do peer evaluations of their communication in the groups. So it's intentional in a way, not in a way, but it is intentional to help them to be able to find the words, find the terms to represent the good of the patient, however that good is determined, even in the midst when you could be humiliated, or you could be shamed, or your ego is at stake.
Yeah, so, and I would just build on that, or maybe put a different spin on it and say one of the things we try to get them to think about is not an immediate reaction that this is a compromise that has to be made, but to think about what is integrity, who is this for, how far can I compromise my position because it's really not about me, and when do I have to really think about this is not a battle I can take on because it really will alter who I am and therefore make me less able to take care of patients in the future because I'll be distancing myself because my integrity is shaken so much. So we try to also work through some of those stronger philosophical problems to help them think about, you know, there often are no right answers, but to think about what they're there for, that your integrity is not as important in the setting as the patient's needs, and so that a balance has to be struck there, for example.
We're going to take one more question. I'd love to take 20 more. This is going wonderfully well.
I applaud you, first of all, for trying to, and to be educating our young men and women in nursing. Because out of academia, out in the field, out in the offices now, we're constantly being stressed as far as the amount of time you can actually spend with a patient. As far as billing, you know, the whole 9 yards. So how do you actually help your students as far as making this transition from what the ideal, you know, nursing philosophy and such and nursing practice should be and keeping up the dignity of the patient? And what are the nursing ethicists trying to do on a political level to try to change this, which has become quite a medical and nursing disaster, you know, and it's causing a lot of burnout. How do you keep the students from burning out, you know, after they've been in the field for 5-10 years? Just would like to get your perspective. And again, thank you very much for all the work you're doing.
So that's a huge one. And, you know, part of what we do also in a faculty level, I think, is think about, you know, the social justice issues and how collaborations can be made to address them. But I think we're not always as good about that as we should be, because we should be leading the way about, you know, how to address those issues. So we do educate our students about how you manage those situations while also being involved in your nursing organization and at a higher level. I think a lot more work needs to be done on that, and I think it's going to take all of us, and it's going to take us co-opting other professions who are also being squeezed and not able to do the work they feel they should be doing. So I think that's a trajectory that really we cannot let go, but I don't have an immediate answer to it except what we do in classes, try and make them politically savvy and also give them a passion for doing something about it instead of saying, oh, well, it's everybody's doing it, can't get away from it.
I do think that that's the key, that some individuals may have a calling to this, and so we can facilitate that calling to be politically active or to help nurses collectively in our organizations move our goals and our objectives as a profession, as a discipline, on the health. Yeah.
So I have to say, hearing you make that comment, and you've graduated someone who has stepped into that calling with Karen Daly,
Okay.
and who is the president of the American Nurses Association, who has taken a very active role in, let's just call it pushback. Yeah. So you go, Karen.
You want to say one more
Yeah,
thing?
just quickly to say that in the hospital setting, I appreciate what you're asking of us. I think that once one has been in a role for some time and has built credibility across disciplines, then in this role we can embrace more challenging problems, for example, with physicians and with administration. And for example, one of the discussions that we've embraced this past year in a forum at MGH led by calling it, an ethics forum, is the idea of how quality metrics in ethics come together for the good of the patient. And this would be an example of working within the hospital setting to, push things forward in a way for the patient good, as Pam always says, which is a good thing.
I'm sorry, we need to stop here because the service staff is going to eat all the food and drink they prepared for us. On the other side of that wall, I'm being warned. I apologize to the person I recognized up here. And we can all continue the conversation. As is always the case in this forum, you've been a terrific, informed, alert audience, and I really appreciate that as a moderator. And I'd like to express my thanks to our 4 panelists here. I think they're terrific.